really excited. I'm really excited to be co-presenting with my colleague Jill. In my daily life, I'm an interventional radiology physician associate and sonographer. I feel like I can kind of relate to where you guys are in that when I was coming through many years ago, I didn't go to a dedicated RVT program. It was a credential that I could earn after my RDMS. So I had to do a lot of self-guided learning, but really did enjoy the vascular aspect of my work. So I feel like I can relate to you guys. You're already taking care of patients, you're already scanning, and now you're trying to add this additional skill. So you will see that kind of tone with my talk. And I was kind of joking, this is a vintage talk because it's from the 2000s when I was early in my sonography days. So bear with me here. I tried to make it pretty this morning, but I appreciate your patience with it nonetheless. So we'll get started. So we're going to look at some preoperative vascular mapping for dialysis access. So this is part one. The outline that I've got set up today is, here we go. So we're going to talk about indications for dialysis access. You guys probably already know these, but we're going to do a little bit of review, discuss general guidelines for vascular mapping, learn how to prepare for vascular mapping. We're going to talk about some arterial and venous anatomy relative to mapping, talk about some variations and abnormal findings that you might discover while you're doing these mappings, share just a quick little research study about the use of it, and then we're going to do a single patient example. And then I think this is going to move nicely into Jill's talk, whereas there's going to be a little bit of overlap, and she's going to share more the after portion. So let's get started. So stages of CKD, what is CKD? So this is renal damage or classifies as GFR less than 60 for 3 months or more. This can be related to pathologic abnormalities in blood or urine or imaging studies. Early detection of kidney disease through GFR. It helps detect kidney disease in its early stages, allowing for the necessary intervention and management. And then monitoring the function, the GFR is going to help with indications for what we do next. GFR plays a crucial role in determining stages and how to prepare the patient. So you can see in the list here, stage 1 through 5. I feel like I see a lot of patients in this 3A, 3B area. Once folks get into stage 4, you're starting to think about dialysis. You're being careful about contrast. You're kind of trying to prepare patients, get them in a mind frame for what comes next. But this GFR that we're going to be referencing periodically in these stages are really key and crucial to how patients are being managed clinically. Just some general guidelines though. So we have a patient that is presenting for vascular access. So we're going to need to spend a little time with that chart. Patient evaluation, what is their history, physical exam, venous, arterial, cardiac, pulmonary, life expectancy of the patient, the duration of the ESRD therapy. Is this a patient that's never going to get a transplant? Are we getting them ready for transplant? Have they had prior access like dialysis catheters? It's important to know this information about patients. As far as diagnostic evaluation, venography, this is where this is going beyond ultrasound, but doing venography where we're actually using X-ray or fluoro to evaluate. So this is going to be indicated in patients with edema or collaterals, maybe disparities in extremity size. Maybe they've got a transvenous pacemaker, previous trauma, multiple previous accesses. These patients may just be a little more complex, and it may be that you're doing a mapping and you find some things that suggest that you might need to use venography. Arteriography, the same idea, especially patients with diminished pulses, because this gives us some clues. Maybe there's an occlusion or obstruction or a stenosis that would be important when we're looking about making a connection between the arterial and venous systems. And then if contrast studies are undesirable, MRI, ultrasound. I mean, I think now we're using ultrasound before. So, potential problems we may run into, venous stenosis, prior vascular damage, or seeing altered hemodynamics and cardiac output. So the two big names that I think about when I think about fistulas are this Fistula First initiative. So this is a national vascular access improvement initiative that works to increase the likelihood that a patient is going to get a fistula first, as opposed to graft material. We always want to use the native vessels if we can. And then the DOKI guidelines or the KDOKI guidelines, so the Kidney Disease Outcome Quality Initiative, It provides general guidelines and dictates the order of preference for placement of vascular access in patients. So this is especially important when we're mapping patients and letting them know what anatomy is available. So I wrote this down. This is what it was at the time. And it's likely that it may have changed. Happy for Jill or Lee to jump in on this, but looking at, what is our preference? Where do we want to go? I think the main thing I would point out here is that it becomes a little more creative and complex as you go on. Obviously, number one, we want to go in the forearm as distal as possible, radial artery, cephalic vein, with the thought being that if this doesn't work, we've got to move up the arm, up the arm, up the arm. So I think Jill's talk will be more relevant to this, but you can see once we start switching using graph material on how we're looping things between arteries, but you can see how key the information is going to be in regards to what arteries and veins are suitable for this sort of intervention and the order that they come in. So if you're getting ready to do a dialysis access evaluation or a vein mapping for that, every department's going to be a little different. I referenced the AIUM guidelines. There are going to be practice guidelines. There are going to be guidelines specific to the surgeon that you may be mapping for, what their preference is. I mean, like just this morning, Jill and I were talking about some labs use tourniquets to show that dilation of the vein. Some do not. So it's really going to be important for you guys to figure out, at your institution and with your vascular surgeons, it's multidisciplinary consideration for what vessels to be mapped and what sizes they'd like, et cetera. Say their preference is this area, but what if that area doesn't work? This is their next preference. This is their next preference, so that you're getting these patients timely care. So before the patient, just like we talked about, have they had any prior fistula, grafts, catheters? Have they had DVT in the past, phlebitis? Contacting the care team. So we often will get requests for this, right? So we want to show preference to the non-dominant arm, but we can't always do that. So what is that patient's non-dominant arm? Obviously, you can ask them, but we need to know this information. For your surgeons, do you know that their preference is, radiocephalic? What do they prefer? Especially with that patient, they might have some ideas, especially if they've had prior access before. Like, hey, I'm really hoping we can get into the brachials up higher or whatever. It's good to know that when you're going in as well. It can save time for you. And then gathering your necessary materials like tourniquets if you're using those, gel, your worksheets where you can put information. Now, some things that you may run into, what if this patient has an open wound? What if there's ulceration? What if they have a bandage or cast? What if there's been a trauma? What if this patient can't move for whatever reason? Sometimes you're going to have to get creative with patients, getting them into the right position when you're doing the studies. So during the patient, make sure you got the right patient. Make sure that you've established and you've documented pertinent history so you know this patient going in, especially in regards to prior access, because it can get really confusing in there. And explain the procedure to the patient. Let them know what you're doing. Make sure they're comfortable. We don't want them to be cold. We want those veins to be, we want to see them as well as possible. So you want to put patients in optimal position. And then the highest frequency transducer possible, 12, 15, 8, and then linear probes. So let's be thinking about that too. As far as the mapping breakdown, just generally, I threw these out. So the internal jugular, the brachiocephalic, the subclavian, for central vasculature, arterially, the brachial, radial, and ulnar for venous, basilic, and cephalic. So when we're looking at central vasculature, we're looking for respiratory physicity, cardiac pulsatility, compressibility where you can, utilizing grayscale, color, and spectral. But when you're doing this scan, if you see changes in the waveforms, and you guys have heard quite a few lectures about what these waveforms should look like. So monophase we've learned is a concern in both ways. Low peak velocities, these folks may need more centralized imaging. Is there a central venous occlusion? Is there a problem? Are these patients going to need to be optimized in some way before they have access placed? So these are some images from cases that I took back in the day, just showing some anatomy, what that blood flow should look like, grayscale. So just giving you a sense of that central venous anatomy image. So the normal jugular venous pulse, has a characteristic multiphasic waveform. This reflects the pressure changes in the right atrium throughout the cardiac cycle. This kind of goes back to what Lee was talking about. 3 upward peaks, 2 downward troughs. So we want to see this phasic pulsatile flow within the jugular vein. If this is monophasic, we probably have an issue. So just to give you an idea of what these areas are going to look like. So for the arterial exam, we talked about already, kind of mentioned subclavian, axillary, brachial, radial, ulnar. These are the vessels we're thinking about. So all arterial vessels evaluated with the highest frequency linear transducer you have, 10 or greater is great. Grayscale, color, spectral, pulse wave, however you want to say it. All vessels evaluated for their diameter, peak systolic velocity, end diastolic, and then calcifications. And then I mentioned the duplex Allen test here, not always required, but this is that test to assess the palmar arch for connection of the radial artery to the ulnar artery. I remember doing this in some patients, but I wanted to just mention this here, that it's definitely a consideration when you're connecting vessels. So arteries that are considered suitable for use, in my lab, it was at least 2 millimeters, so 2 to 3 millimeters or 0.2 to 0.3 centimeters. We took measurements, anacube, prox, mid and distal forearm and wrist. Same thing, so upper arm and forearm. They needed to have adequate flow for maturation, and they needed to have minimal calcifications due to possible surgical anastomotic difficulties. So you can see in the diagram here the areas that we're going to be referencing in our report. So just to kind of show you that course and as the branches and how things move through. Just to give you kind of a sense of the area that the surgeons would be working in. So obviously muscles here, but seeing underneath, where the branching to the radial and the ulnar, that arch that we were talking about. So just sort of giving you more of a nice illustration there. So the axillary artery evaluated the proximal shoulder and in the armpit, and may be used in cases without suitable forearm placement. Brachial artery evaluated the antecubital fossa, the bifurcation. It may be used when no access available in the wrist. Radial artery evaluated from origin to wrist. It takes a lateral course towards the thumb. Okay. Ulnar artery evaluated from origin to wrist, takes a medial course towards the pinky, just as a reference. Okay. Brachial artery, I just shared an image here of color measurement, sort of showing that where the brachial artery branches into the radial and ulnar, seeing the paired brachial veins in the image here, seeing the waveform. So just, what I wanted you to notice here is this is a high frequency transducer. We're pretty superficial, obviously. You can see 4 centimeters here. You can see the walls of the artery really well. You can see that measurement. You can see that there aren't any calcifications here. So when you're taking these images, you want to be thoughtful about the optimization, so the knobology as well. The ulnar artery, so an image of the ulnar artery. This is also the labeling, right? They need to know where you are. So right arm in sagittal or long, this is the ulnar artery, and this is proximal forearm. So this will be really helpful for the surgeons when they're looking at your reports to know where that diameter is. And as mentioned with Neil's talk, we've got the paired ulnar veins here, and then the waveform. This, looking in hindsight, could have been optimized, these waveforms. So don't do this. It could be better. This is old Carrie. Okay. Okay. All right. Arterial variants. So unusual takeoffs. I thought this was a cool one. I mean, we definitely can see these unusual things. The bodies didn't get the memo about what all the textbooks say. We have duplications. We have dominant branches. Sometimes we don't find them at all. So just know when you get in there, it's not necessarily going to be just like the textbook. Radial artery stenosis. So I put this in. I thought it was interesting. You can see in the picture here a little bit of the calcification. We put the color on, and you can see it is causing disturbance of the color here, and then actually sampling in that area to see how relative that stenosis might be from the calcification. So these are also going to be helpful things for your surgeon based on their connections, because stenoses are going to cause problems with the loop. and may impact maturity and other things. So it may be that they want to select a different area, and maybe they say, hey, let's look at the ulnar. This obviously isn't that severe, but it is something to note for them. So like here's an example of an arterial calcification. Pretty tight stenosis there. So this is not going to be a great candidate unless they're going to go in and clean that out or make some modifications or do some work to that. But the most common and desired placement of AV fistula is in the forearm. So, below the elbow, and we're looking at, as we mentioned, brachial, radial, ulnar, and then axillary is more proximal. So if we don't have what we need here, moving more central. Venous exam. So subclavian vein, brachiocephalic vein, axillary, brachial, median cubital, basilic, cephalic. So just kind of a quick little review there. So we're talking about using the non-dominant arm unless that's contraindicated. The MAP vein is considered dilated, so closely approximates the size of the arterialized vein, right? If you think about the fact that we're going to be running this mixed flow of blood through there, the vein itself is going to need to be able to compensate for that pulsatile arterial flow. Maximum venous diameter measured. So techniques include tourniquets, blood pressure cuffs, arm positioning, percussion of the vein, wrapping the arm with a warm compress. Maybe you've got a patient that's close, but not quite to your criteria. But then some, like Jill was saying this morning, some surgeons say don't put tourniquets, don't do things to these vessels because we don't want to damage or harm them in any way. So it'll be specific to your department, and you'll need to check in with the folks that you're doing these mappings for. And all veins are evaluated for three important things. So dilation prior to insufflation, demonstration of adequate size, so 2 to 3, and normal compression and adequate drainage. Okay. And then this is just another diagram of kind of showing you these landmarks. So when you're looking at the subclavian vein, obviously you're dealing with the clavicle here a bit. Other muscles that you're going to be coursing through, like here, the basilic vein pierces through the fascia and becomes a deep vein in the upper arm. So you see different variations of these. If you Google venous anatomy, you get so much free source information. But the main idea here to demonstrate is, where the basilic vein is located, where the radial veins, ulnar veins, cephalic veins. So I always taught was brachial basement, cephalic ceiling. So you have little ways that you can remember things. The cephalic vein most commonly used in the forearm when possible in the wrist. It takes a lateral course from the shoulder to the wrist. I would say the cephalic vein can be hard to find sometimes. It can be small. It can be easy to get off of it. So that one sometimes can be hard, especially if their arm is cold. Accessing for compressibility and a minimum diameter, as we mentioned before. Taking those measurements at the origin, prox, mid, distal, upper arm, anacube, prox, mid, distal, forearm, and wrist. So note size and length of any venous stenosis as well. It needs to be relatively superficial is the thought. Sometimes you might want to give the depth if it's deeper in a patient with a larger body habitus. I mean, I know surgeons do have the ability to move these veins and do different things with them. You also want to note any large branches near the fistula site. This can lead to non-maturation, or they may need to ligate them or work on them. If greater than a centimeter, may have to be recorded. Must be evaluated central to the draining vein. So any unusual takeoffs or size variations need to be noted. And if the cephalic vein is not adequate in the forearm, other vessels must be evaluated. Sometimes they have to be transposed to a more suitable position in the arm. So this is an image kind of showing that cephalic vein takeoff because you're dealing with the clavicle there. It can be kind of small at the takeoff. This is actually 4.5, but just giving you a sense of what that can look like as you're kind of having to angle back behind the clavicle. And here's a nice diagram. The basilic vein. So you're locating the basilic vein as it joins the brachial vein and takes a medial course towards the wrist. Measuring from the origin in and around the axillary region to a distal diameter of at least 2.5. You're showing compression, you're showing diameter measurements, flow determinations, At the antecubital fossa, you can see potential venous anomalies like a Y-shaped connection between the basilic and cephalic. So it can get a little interesting in the anacube. So you want to really try to map that out well. So 2 centimeters of adequately sized basilic vein distal to the antecubital fossa is necessary for a transposition. And if not possible, the largest brachial and axillary vein are measured for graft placement with a minimum diameter of 0.4 centimeters. So if you don't have what it is they need, then you've also got to be thinking ahead of what comes next. Some venous variants. This is a patient that had a basilic vein duplication. So it's going to be out there. Pay attention if your patient has access, if they've got an IV or some other kind of access that you may see an intravenous line. Okay, this is also important to note. Typically, nephrologists don't like you to have access in vessels that may be used for dialysis access. This is the idea behind let's save that arm that we may want to use for dialysis. Let's not put any vascular access there. This is a patient with clot. I mean, the patients that you're going to be mapping are going to have these same issues too. So you've got to be looking out for this. So this is an internal jugular vein clot, as you guys can tell from the prior talk. This is non-compressible. This is new looking, the high echoes. You can actually see, it looks edematous almost around the vein here. And then this is a patient completely occluded centrally. So normal like we saw before versus that occlusion. So we've definitely got a problem here for that patient. Cephalic vein thrombus. The cephalic vein is commonly used for IV access. So in this particular patient, you can see, we see that bright echo within the vein. When I go to compress, it's not compressible. You can see the clot here. So the surgeons are probably gonna want to avoid using vessels with clot in them. So it's important to note these other things as well. This is an angiogram image of cephalic vein collaterals. What this tells me is probably this patient maybe had an IV before and had a clot before, has an issue already. So just to show you the kind of the translation from what we see on ultrasound to what we might see with venogram. And after the patient, you're going to be filling out that worksheet, whatever that is. We're going to kind of help with that when we're there. Drawings, when unusual anatomy is found, this is going to be huge. Sometimes it's hard for folks to make that translation from what is being seen in the ultrasound images to what it's actually looking like on the arm. Follow up on the dictation, see how they read that out. And then this is how I learned. Follow up on the patient, see what kind of access was placed. That really helped me. And I thought that was a big part of my learning, knowing, okay, they picked this artery, they picked this vein, this is the location. It helped me to be more helpful to them in future mappings, okay? So just a quick little study here, very small group of patients, but this was done at the University of Alabama Hospital in Birmingham. They were basically studying the effect of preoperative ultrasound mapping on surgical selection, placement of AV fistulas and grafts, and any negative surgical exploration rates. So they picked 70 patients with chronic renal failure that had arterial and venous mapping before surgical exploration. The surgical team documented their planned access based on the physical exam and vein mapping results, and then they recorded what was actually done. So 52 of the 70 that were mapped actually had access placed. So in 16 of 52, or 31%, the mapping changed the planned surgical outcome. So an AV fistula was able to be placed in 8 as opposed to the planned graft. So that's huge. The AV placement rate increased as compared to the prior 2 years, so from 32% to 58%. So over half the patients. And then unsuccessful surgical explorations decreased from the prior 2 years from 11% to 0. So basically, they didn't need to look around in there and figure out what they were going to connect. They had the right information going in. So the mapping can change surgical management. It increases the likelihood they're going to get the most functional vessels selected preoperatively. It reduces unnecessary surgical explorations. Those complications can cause morbidity, hospitalization, and then more cost for hemodialysis access patients. So I'm just going to walk through one patient here, and then I'm going to hand the mic over. I know this has been a whirlwind, but you guys have looked at arteries, you've looked at veins, you kind of have a sense. It's really just to let you know where we're looking in the arm, and I think the hands-on is really going to be where this comes to life. So patient X, so typical patient, male, 15-year smoking history. I had to change the date of birth today because the person was no longer alive. That's how old the talk is. The patient history is stage 5 CKD, so it's time. Ischemic cardiomyopathy, coronary artery disease. They've already had a 3-vessel coronary artery bypass graft. They have atrial fibrillation. They have hypertension. They have type 2 diabetes. They've got peripheral vascular disease. They've had a stroke. So, the patients that we get are, they're not, just walking off the street typically with no issues. These are sick patients. So we're going to call them patient X. They were admitted to the nephrology service. So we'll say around April 6th of 2009 with uremic symptoms, primary malaise. They were pruritic, they were itchy. Their BUN and creatinine were abnormal. They're undergoing dialysis in an outside facility, but they're here to get more permanent dialysis access and resolve current issues. So the nephrology team asked for a right IJ permacath, so the patient could continue to be dialyzed while in the hospital via that permacath or dialysis catheter. Then the nephrology team the next day ordered a mapping. And based on that mapping, we found that cephalic vein was usable in the upper arm, the basilic vein was usable in the upper arm, and the axillary artery and brachial artery were usable. So they've got some things that they can use. So on the 17th, so a little bit of time passes, they meet the surgeon to discuss their long-term placement, and the surgeons elected for brachiocephalic fistula. This was planned for the 28th, so they were going to be admitting the patient to get ready for that. So the patient was able to get a fistula. They got a brachiocephalic fistula in the non-dominant arm. The median cubital vein was used as the inflow for the fistula and the cephalic, and the brachial artery is used for the outflow. So in summary, we want to consider these DOKI guidelines and this fistula first idea. The arterial exam, the big areas we're looking at are brachial, radial, ulnar, the diameters. What is that diameter going to be for your department? Is it 2? Is it 3? Velocities, noting calcification, any abnormal waveforms, venous exam, jugular vein, subclavian, brachiocephalic. We're looking basilic, cephalic. Sometimes we need to look at brachials. Do they compress? What is that diameter? Is it adequately draining? Are we seeing any clot? Are we seeing any changes in the waveform? So looking out for these vascular abnormalities and anomalies, establishing a good rapport with the patient, because you're probably going to see this patient again if you're mapping them. You may have to map them again down the road. You may be seeing them next time because they have their fistula and they're having a problem with it. So make sure that you want to take that time to establish a good rapport and then establish a strong multidisciplinary community, which it sounds like you guys already have that, because as a sonographer, you want to be able to relay this to your radiologist and say, hey, what about this? I'm concerned. I can't see the radial well, but the ulnar is kind of small. You guys want to be able to talk through this, and then also to be able to reach out to the surgeon and say, hey, I saw your patient today. I know you're in a hurry to get this done, so we've got this, this, this. They're good to go. So I think having that community is key. So here's a happy winner, someone who has nice access, and he's very happy about it, as you can tell. I'm sure this image looks like it's probably from the 70s, maybe. I don't know. But anyway, the references are old, but I think they still hold true. So I am going to pass the mic to my colleague, Jill. Take it away, Jill. I hope that was a good opening act for you.
It sure was. Thank you so much, Carrie. That was fantastic. We may overlap just a little bit, but I think sometimes we have just a little bit different purview of mapping these patients in each practice. So just to introduce myself, I'm Jill Somerset. I'm a vascular sonographer, and I am lucky enough to work with Carrie. And I can't thank Kaiba and Lee for the invitation to be here and to share this information. I worked in a small community hospital that was very busy in the United States, just in Washington State. And so what I'm going to talk about today is maybe just a little different approach to how we pre-map these patients. As Carrie really well covered the anatomy here, what I'd like to talk about is ultrasound first for all of these patients in consideration for an arterial venous fistula. And so the way that we approach these patients from an ultrasound perspective is we are really interested in the cephalic and the basilic vein. So, but we also have to look at the venous and the arteries of the upper extremity. But I don't want to start looking at the entire arterial segment if the cephalic vein and basilic vein are not suitable for dialysis. So I like to start in the non-dominant arm. We're going to start looking at the cephalic vein, and we always start distal. And usually the cephalic vein is the vein of choice. So the reason is it's usually superficial and easier to create a little fistula versus basilic are deeper, and it's usually either a second stage, but we do have to lift it up because it is deeper anatomically. So this is a very busy slide, but this is our algorithm in our practice where we begin with the non-dominant arm. We're going to evaluate the basilic and the cephalic vein. In our practice, we like a vein 3 millimeters or greater, and you can use a tourniquet or not, depending on the surgeon's choice. And if that vein is suitable in either one, we're going to continue on with our evaluation. And we're then going to look at the artery inflow and the venous system. If these veins are less than 3 millimeters, we're going to go to the other arm because we want to use native vein. And if the cephalic and the basilic vein are not suitable, then we are going to go to the dominant arm. Now, one could argue, well, we could put a loop graft in the non-dominant arm, and that's really surgeon's choice. So if the non-dominant arm is not suitable, then we'll go to the dominant arm and map the basilic and cephalic. And if they're suitable, we'll go ahead and continue on with the full arterial and venous mapping. So this is just a list of just reiterating what I reviewed, but any of these worksheets or diagrams that you're going to see, I am happy to share them, and they're blank, and you can certainly use them in your practice. But again, starting with this non-dominant arm first, mapping the cephalic and basilic vein, 3 millimeters is certainly ideal, and then you're definitely going to document depth because we want to know if we need to lift that vein up for cannulation. And then we're going to evaluate the arterial inflow system and then certainly the venous system. There's nothing worse than having good veins and big central venous obstruction. So we can't forget about the central venous obstruction issue that we know about. So we're going to start distal when we evaluate the cephalic vein. And then we're just going to move up the arm. And we're going to look in a transverse view and document compressibility and the diameter of the cephalic vein. And just like Carrie talked about, the medial and acubital veins are really important because you could have a pretty decent size anacubital vein and the cephalic vein is maybe just a little on the small side, but it will plump up and we can use that as a surgical anastomosis site. For the basilic vein, I usually start at that anacubital fossa, just like Carrie said, and then we work our way up. We know that this is a shorter vein here. And so if you think about, we have to either do a two-stage or single stage, meaning we have to lift it up and create the AV fistula, but sometimes that basilic vein can be really short. So we like to know where it confluences with the either brachial veins or axillary veins. So it's really important to note the length of that basilic vein. So these are some of the things that I really pay attention to. So I just started my duplex ultrasound on the non-dominant arm, and we want to make sure we use very light probe pressure in the cephalic vein because generally it's just more superficial. And we want to, so you can see my probe is not well adapted to the skin because I'm trying to use really light probe pressure. And then we're going to measure inner wall to inner wall. And then we can certainly, do compressions and make sure there's no chronic superficial venous thrombosis that existed. In this situation, the cephalic vein is 2.2 millimeters, which is too small in our practice. And so therefore, I'm going to go to the basilic vein, which again, a little lighter probe pressure, measuring inner wall to inner wall, doing our compressions. And then if we measure the diameter here, it's really nice. It's 4.5. But what's important here to note is that the depth is deep. It's 7.4 millimeters, and we aim for the depth to be less than 6 millimeters. So this is a patient that would need it transposed and brought to the surface. But it is a very nice and healthy basilic vein that we can use for a brachial basilic. So these are things I'm kind of thinking about as we're mapping this upper extremity. So now we know that the cephalic vein is too small. The basilic vein is certainly amenable for AV fistula creation. And now I'm going to look at the central veins. So here's a compression of the subclavian vein. This is infraclavicular. This can be really hard sometimes to evaluate, so you can use the proper probe. This is a linear probe, but sometimes I do switch to a curvilinear probe if you have it. And then we can turn the color on, turn the probe in a long axis view, and appreciate that nice full color filling. We don't have any chronic thrombus sitting in there. And then most important is this Doppler waveform in the subclavian vein. This is a spontaneous and phasic flow, telling us indirectly that there is no hemodynamically significant central venous obstruction. If you see a more continuous waveform, that is certainly abnormal. And if you need to, you can always compare side to side of that subclavian vein to say, is it really abnormal? Let's look at the other side, because it could be in the superior vena cava as well. So just really pay attention to this subclavian waveform to basically say, is it free from any central venous obstruction? So moving on, Carrie really nicely laid out the upper extremity. I like to do almost a spot check. You can do just the subclavian artery. This is a normal multiphasic arterial waveform. The brachial artery would also be multiphasic, but I like to just jump down to the radial artery as well, and the ulnar artery. And as Carrie talked about, we want to make sure that brachial artery doesn't have any, stenosis. So we want to make sure that it's clear of any disease. But this patient has a very clear, open arterial system on the upper extremity. So then when we look at this diagram, and we fill in our numbers, the cephalic vein is really too small for our practice. So then we look to the basilic vein. Again, this is the non-dominant arm. Yes, these are greater than 3 millimeters, but we got a depth problem. So this is going to be either a single stage or a two-stage procedure to transpose this brachial vein for creation of the AV fistula. And so we can also, when you look at this worksheet, you can look at the diameter, the depth, you can look at the venous system here, saying it's all normal. There's no venous obstruction. And then we can quickly go to the arterial inflow to say, hey, this is all multiphasic normal waveform. This is a nice worksheet to work the patient up and say, okay, we've got a plan. We can do a brachial basilic. If we were to scan the dominant arm, there's no cephalic vein. They harvested it for a lower extremity bypass. And in this basilic vein is certainly also of amenable size, but again, it's the dominant arm. So we're going to stick with the non-dominant arm for this patient. So there are many different types of AV fistula and grafts that Carrie talked about. We generally like to start as far distal, so a radial to cephalic, arteriovenous fistula. If that distal radial or cephalic vein is not of adequate size, then we can move up to more of the antecubital fossa. And we then look to the brachiocephalic. And then we can also look at the transposed brachiobasilic. And then last option is a loop graft. So in the setting of no suitable veins and we're going to think about a loop graft, I'm certainly going to be thinking about the surgical anastomosis of the arterial inflow of the brachial artery or axillary artery. It's going to loop around the arm, and then it's going to plug back into the venous system. So we just want to be thoughtful about the planning and making sure all of the veins and arteries are clear from any obstruction. Let me just move on here. So yeah, with those loop graft, PTFE, there's many configurations. It can be forearm or upper arm, and I've even scanned them in the upper thigh as well. So when we evaluate post loop graft, we certainly want to make sure that we understand the inflow arterial flow. We can Doppler within the loop graft, and then we want to know what the venous anastomosis is as well, because the arterial and venous anastomosis are usually the modes of failure for these dialysis loop grafts thrombosing or going down. So it's really important to evaluate both arterial and venous anastomosis, as well as the inflow and outflow, like what is causing this loop graft dialysis graft to go down. Okay, so Carrie did a nice job of talking about the Kudoki guidelines. I like to use the rule of sixes. It's very simple. I think, there we go. So the rule of sixes, quickly in your mind, is we want the depth of the fistula that we're going to cannulate to be less than 6 millimeters from the surface. We want the diameter to be greater than 6 millimeters in diameter. And then we need about 6, actually centimeters, sorry, that's a typo, long for access. And then the flow volume, whether you use brachial artery inflow or outflow in the venous conduit, we want it to be greater than 600 milliliters per minute. So in this type of situation, this patient has had a AV fistula. This is a brachiocephalic. And you can see the diameter here is 8 millimeters and the depth is less than 6. And that's really fantastic for cannulation. And then the flow volume is greater than 600. So we use this language, is it mature? Can we use it for successful dialysis? And the answer is yes. So we have these metrics, this rule of sixes, that is really quite helpful when we're analyzing the patient to get them ready for dialysis. So again, the protocol that we have, and again, I'm happy to share the written protocol, any diagrams or drawings that would be helpful in your practice. But we certainly want to evaluate the inflow artery proximal to the arteriovenous fistula. And in this diagram, you'll see here's the arterial inflow. You have all of that information right here. We're definitely going to evaluate the anastomosis. And then we're going to move through the conduit as well. Now we can't forget about the native radial and ulnar artery because they are supplying the hand. We know that these arteriovenous fistulas can sometimes steal from the hand, and that creates ischemic ulcers or pain. So we just want to make sure we evaluate the ulnar and radial artery. And you'll see it listed here on the worksheet. These are just peak systolic velocities. And then the fistula is all down here, so we can understand the peak systolic velocity of the anastomosis and the depth as well as the flow volume. So we're just going to trace this AV fistula out here. You can see it's a little bit dilated, and there's a tiny little dissection, and then a little parasitic vein. And we see these sometimes that can kind of steal some of that volume out there. So this is like a mapping of exactly what we're scanning, which is a really nice picture to say what's going on from a hemodynamic situation of this patient. And then we certainly follow this, this is a brachiocephalic, out to the shoulder because we want to make sure that there's no central venous obstruction in this confluence. You can see it goes from 128 centimeters per second at the shoulder to 308. And that's just a little bit of a jet. It's pretty common, right? As Carrie actually showed that really nice image as the cephalic vein confluences with the distal subclavian. It gets sometimes a little pinch there, and it's kind of a common area that we need to go in and do balloon angioplasty. So this whole diagram is really helpful to show the patient, but also for the multidisciplinary team to really understand what's happening with this particular patient. And so from the required measurements that we like, again, is the depth, the luminal diameters, and the flow volume. You can document these parasitic veins that I talked about because sometimes they steal. So let's talk about normal findings. So post AV fistula creation, we expect the arterial inflow to have higher end diastolic flow. This is now a low resistant arterial waveform. And so if you have a high resistant waveform, you know that something's wrong. So in all of us, we have this high resistant multiphasic subclavian and brachial artery waveform. In a patient with a patent and functional AV fistula, it becomes this low resistant waveform. So we look for these flow patterns as indicators of what's to come. So we certainly want to make sure that there's no intraluminal defects. We look for aneurysmal degeneration of the outflow fistula. You know, we're putting these, we're cannulating this vein wall, and it's certainly subject to getting dilated. And so you can see here, this is a really nice low flow because we're coming centrally now. This is an arterialized waveform in the venous system. As far as flow volume, we want to make sure that our technique is correct. So you want to be parallel with the vessel wall. Usually we try to get a flow volume in the straight segment. There's some people who like to get a flow volume in the inflow brachial artery, and some like to get it in the outflow cephalic vein. And either way is probably just fine. This particular image is in the outflow cephalic vein, so we want to make sure we have a nice long open vessel that's straight. We want to be at 60 degrees angle corrected properly, and we're going to open up our sample gate so it's wall to wall. And then on our ultrasound systems, we have the flow volume setting where we can push the setting for flow volume. We're going to put our wall-to-wall cursors up, and then we want to get about 3 to 4 cardiac cycles to really get a reliable flow volume. Again, here's another example of, this is in the radial artery, but we can get it in either place here. Sorry, there we go. Just another example of proper technique. Now, from a criteria standpoint, if you're going to take it in the outflow vein, for example, if this was the cephalic vein, the criteria that is published here, that referenced in 2005, what we want to do is take the flow volume 2 centimeters beyond the anastomosis. So, and here's if we have a 2-to-1 ratio, it's greater than 50%. If it's a 4-to-1 ratio, it's greater than 75. So if here's the anastomosis, I usually measure 2 centimeters beyond the anastomosis and take my flow volume here, proximally, and then I take another one. So I usually do 2 flow volumes in the fistula. Again, you can take it in the brachial artery inflow as well. So some abnormal findings is, again, if you place the probe in the subclavian or brachial artery and you see a high resistant waveform with no end diastolic flow, you know that the fistula is likely thrombosed or occluded, or it's down, or it's impending failure. And then in the outflow vein, we look at the flow volume, but I also look at the peak systolic velocity. And there's data to say that if the velocity is less than 100 centimeters per second in the outflow fistula, that is indicative of impending failure. And we probably need to do something to keep this fistula open. And again, here's that ratios. When we look at quantifying stenosis, we just use ratios proximal and then at the area of stenosis. So again, we have to really make sure that we don't have central venous obstruction. These patients who have prolonged bleeding after dialysis is a clear, indirect suggestion that they have something centrally happening. So as soon as I know a patient is having prolonged bleeding, I'm immediately thinking it's probably in that cephalic confluence, or there's some central venous obstruction. So usually outflow is the most common place for stenosis, not so much inflow disease. So let's talk about a case here. This is a patient who had an AV fistula. This is a high radial cephalic AV fistula creation. And this was 30 days after the placement of the fistula. So when we look at these numbers here, I am looking at the diameter of the outflow cephalic vein. Remember, we want it to be greater than 6 millimeters. I'm also looking at the flow volume. Remember, we want it to be greater than 600. This patient has very nice arterial inflow. The anastomosis is open, but this diameter is not quite mature, nor is the flow volume. And if you look at the arrows in the radial and ulnar artery, we do have retrograde flow in the radial artery to suggest some component of arterial steal. However, the patient is asymptomatic. So nothing to do there. So the question is the graft mature? Not quite, it's almost there. So we just need to give it a little bit more time to mature. This patient is not ready for hemodialysis. And so, yes, there is retrograde flow in the radial artery, but as we know, steal is a clinical diagnosis. The patient has no wound or no pain with or without dialysis. So 60 days later, we have the patient come back, actually a month later. So this patient is 2 months post AV fistula creation. And now we see an improvement in the size of the cephalic vein to 7 millimeters. It's fantastic. And the flow volume is over 600. It's 736. And the radial artery is still retrograde. That's fine. The patient still remains asymptomatic. So this would be a patient then, based on the ultrasound, we make decision making of when the patient is ready for dialysis. And it's important not to just stop at the mid outflow fistula. We have to follow it all the way up to here's the confluence of that cephalic into the subclavian vein. And then we follow the subclavian vein to ensure there is no central venous obstruction. So we watch these velocities as we follow it all the way to the central part of the chest. So in summary, ultrasound is this really nice tool to not only plan, just as Carrie said, it can really be a helpful tool in planning for our dialysis access procedures. We can go through this protocol pretty efficiently and accurately to say, where are we going to place this AV fistula? What is the plan and what's best for the patient? And so post AV fistula creation, we can use this tool non-invasively to follow these patients to say, are they mature for dialysis? Maybe they're having trouble with dialysis with prolonged bleeding, or the pressures are high. And so we can use this ultrasound tool to, help decide the care and treatment pathway for this patient. So I'd like to say thank you very much. And again, I'm happy to share any diagram if anybody is interested, or even any written protocol.
Thank you. Lizette, we can stop the recording. Okay.